So I'm going to talk today about XmAb819. This is another program that's near and dear to my heart. It's a bispecific for clear cell RCC targeting ENPP3 and CD3. So this goes back all the way to 2022. Phase 1 study presented at SITC, and this was back when it was myself, Dr. Paul, and then Pablos from MD Anderson as well, working with Xencor as just our three sites and really trying to figure out how to give this drug, given its unique targets that I'm going to get into right now. So what does ENPP3 do in the body? Forget cancer. It's challenging. It's involved in allergic inflammation, and I tried to grab this diagram here to explain it. Basically, what happens is when you have basophils and mast cells, they're secreting ATP upon activation, and through cross-linking mechanisms, you actually can induce less allergic inflammation by ENPP3 hydrolyzing that ATP. In a mouse model, when you reduce ENPP3 and knock it out, you can see that you have continued chronic allergic inflammation because you don't have any more of that ENPP3. So this is an example of how this is involved in allergic inflammation. And of course, when we start thinking about how do we target and leverage this in cancer, we have to think about the biological rationale in the human body first. And then when we look at expression in normal and tumor tissues, I highlight in dark red here, the clear cell RCC has a lot of ENPP3 expression, making it an ideal target to study for a therapeutic benefit. But it is presented in some other places at low level as well. So on that top row of the histology slides there, you can see normal kidney cortex, fallopian tube, stomach, small intestine, and colon. But then I'm going to draw you to the right side of this slide here, where you can see that normally in healthy human tissues, ENPP3 is expressed more in the apical surface, which maybe means that it's going to be harder to actually hit when we provide a therapy that targets this. However, in a cancer cell, obviously you have dysregulation of the microenvironment, and all of a sudden you have more exposure potentially to the bloodstream to get this therapeutic modality straight in towards the cancer cells, perhaps sparing host tissues and targeting the cancer tissue more. It's not just in clear cell renal cell. Also, there's some expression in papillary and HCC, and I'm going to show another study that shows that. So this is data that was presented along with the rationale for this drug back in 2022. You can see kidney highlighted in red, decent expression in this solid tumor, but you can see expression in colon, breast, lung, prostate, and other places as well. So making it a really interesting target, not just in clear cell, which is obviously the tallest peak on this graph, but in other solid tumor malignancy as well. And then another study looking at this, and this was presented back in 2024. This is internal data. This was presented at AACR, so not too long ago, on another compound I'm working with from J&J, also targeting ENPP3 CD3. So we have two of these at our site and are happy to have them slightly different mechanisms, slightly different modes of delivery, IV versus subcutaneous. But you can see here in their data sets, ENPP3 very ubiquitously expressed in clear cell RCC, 78% expression in papillary, and then you can see the gynecologic malignancies as well as colorectal and lung. So another proof of concept that this is a good target in kidney cancer, of course, as the primary modality, but also in other solid tumors as well. So that brings me back to XmAb819. So this is a 2+1. And you can see here the design of this T-cell engager, this bispecific, is that it has two targeting ENPP3 for the one that's targeting CD3. And what's interesting is that this is the same XmAb platform that actually AMG 509 borrowed to make the STEAP asset that Oliver was presenting not too long ago, which shows that this platform is already showing nice data and is exciting. This 2+1 modality may be a better answer to create these T-cell engagers that we can use in our clinic. So that's exciting about this platform. And then when you look at the preclinical rationale, you can see they showed obviously 2+1 format promotes preferential killing of the ENPP3 high target cells, not surprising, and it moves forward into the clinic based on this data. And then when you look at xenograft models, you see the same thing. You can see very clear reduction in the tumor volume as you bring this bispecific into those models. So what are we doing on this study? And this is what I can tell you. This is the original IV dosing schedule. It is weekly, and weekly is a big challenge for patients, especially patients traveling to phase 1 centers, because they don't always live within 20 minutes of the clinic. But this is how it was given. Obviously, other dosing schedules are being explored currently that I can't completely share with you, but other ways to figure out how best to do this. And then going back to the unique toxicities, first we'll talk about cytokine release syndrome and then about skin tox. So this is something that used to scare me a lot back when I first started giving these drugs. Now that I've worked with 8 different T-cell engagers, it's a little bit less challenging. The key is anyone in this room can do this as long as they want to. And the key, it's just don't turn off your cell phone, right? So when I have a patient in the hospital on one of these drugs, it's me. It doesn't matter if I'm here. As I was traveling to this conference Thursday, I had a patient who was on one of these drugs getting a dose escalation or elsewhere. You really do have to be responsive. But if you are responsive, it's pretty algorithmic in the management, right? So grade 1 is a fever. Grade 2 is a fever. Maybe you need a little bit of IV fluids for hypotension or low flow nasal cannula. Grade 3 is when you start having to think about the ICU, needing the vasopressors or high flow oxygen, et cetera. And grade 4, I've never actually personally seen on a T-cell engager. Obviously, we see those in our cellular therapies with CAR T, but of course, they do happen on these studies. They're reported. I've just never personally seen it in Nashville when I give the therapies. Oh, and the other thing I mentioned is obviously skin rash on these drugs is something that we have to think about given the allergic inflammation that I mentioned on that front slide. So in the last 10 seconds, though, it's not just ENPP3. There's future potential targets for bispecifics and T-cell engagers and clear cell RCC. I think these are some interesting targets like CA9. Obviously, CD70 has a lot of CAR T activity, but also bispecific activity is potential there as well. And, you can go further down the list of other targets. And of course, even PSMA has been discussed as a potential target in certain RCC. We do have a way to image that and see if the tumor cells are expressing it. So obviously there's enough PSMA engagers out there that's worthy of exploration too, though not on this slide. And with that, I'll turn it over to my other Vanderbilt colleague.